Shall we start, Manjula?
Yes, doctor.
After successfully conducting themed retina meetings for the last 5 years, we present Fibrosis 2025. In 2021, the theme was angiogenesis. In 2023, we focused on atrophy, and now we're exploring fibrosis. A very warm welcome to all attendees of the Fibrosis 2025 meeting.
So, good evening, everyone. To everyone who has joined the webinar, we are truly grateful for the overwhelming response and keen interest that this meeting has generated. This year, we aim to bridge the gap of bedside and clinical science under the theme of fibrosis, and it has been a privilege to host esteemed speakers who have shared their valuable insights. Your participation has made this program truly enriching. So today we focus on proliferative retroretinopathy and epiretinal membrane, and with our speakers offering their expertise on these critical topics that impact surgical outcomes. So for our first session, we have Dr. Hardeep Singh Mudar, consultant pathologist in Sheffield Eye Hospital, and a little about him. He's trained in medicine in Guy's Hospital Medical School, Cambridge, PhD with at UCL Neurobiology, and ophthalmology training at Queen's Medical College, Nottingham, histopathology training in Sheffield, and he's rotated through all the UK specialist ophthalmic pathology centers. And he'll be talking on histopathology of PVR. So let's listen to him.
Hello there, my name's Dr. Hardeep Singh Mudar. I'm a consultant in eye pathology in the Royal Hallamshire Hospital in Sheffield, and today I'm going to be talking briefly about the histopathology of PVR. PVR is a term that was originally used in a seminal paper published by the Retina Society Terminology Committee in 1983, with further revisions in 1989 by the Silicone Study Group. And it's an intraocular scarring process that complicates up to 10% of regumatogenous retinal detachment cases, and is one of the main factors that lead to failed retinal detachment surgery. It comprises the production of epiretinal and subretinal fibrocellular membranes that contract and convert a regumatogenous RD into a tractional RD. There are three basic processes that lead to the production of PVR: retinal ischemia, inflammation, and cellular proliferation. So the photoreceptors separate from the RPE, and this leads to outer retinal ischemia. This leads to the death of photoreceptors by a variety of cell death processes, principally apoptosis, necroptosis, and programmed endoplasmic reticulum stress-mediated cell death pathways. So there are two processes that ensue when the retina separates. One is an intraretinal process whereby there is glial remodeling and proliferation of the Muller cells in the retina that leads to intraretinal PVR, and this leads to retinal shortening. And the other, of course, is the production of spindled fibroblast type cells from the RPE, known as retinal transdifferentiation, that is caused by a process of epithelial mesenchymal transition that leads to migration and proliferation of these cells, of these differentiated RP cells, that leads to contractile fibrocellular membranes on the epiretinal and subretinal surfaces, and both these processes then lead to preventing the retina from reattaching. There are three principal cell types involved, therefore, in PVR production: RP cells, glial cells, and inflammatory cells, principally macrophages and microglial cells. We know that RP cells are present in surgically removed epiretinal membranes. Under normal circumstances, cuboidal RP cells are mitotically quiescent due to cell-to-cell contact suppression. When the RP cells are exposed to serum factors due to damage of the blood-retinal barrier from RD, they detach from Bruch's membrane and undergo a very important pathological process of epithelial mesenchymal transition. This process confers the RP cells with considerable migratory activity, invasiveness, and resistance to apoptosis and production of extracellular matrix proteins, which then lead to fibrosis. These transdifferentiated RP cells proliferate and migrate through the retinal breaks to assume an epiretinal location, and under the influence of growth factors proliferate and undergo chemotaxis towards this particular location. Here we have a nice diagram from the paper from Kaneko and Terasaki, which shows the transition of the cuboidal RP cells to spindled RP cells under the process of epithelial mesenchymal transition. Now, this EMT process is very, very important and is caused by Zeb, snail, and twist proteins. And these proteins activate a variety of genes, such as endocadherin, vimentin, beta-1 and 3 integrins, and matrix metalloproteinases that induce a mesenchymal state and repress the genes that are involved in an epithelial polarity. The mesenchymal state, of course, confers the RP cells with considerable motility and invasive properties. There are a variety of intracellular pathways that are involved in epithelial mesenchymal transition. In the center of the diagram, you can see that the TGF beta family of receptors and the ligands are implicated. TGF beta is present in high concentrations in eyes with PVR and induces EMT and type 1 collagen and extracellular matrix production in RP cells via the SMAD intracellular signaling cascade. It's also involved in contraction of epiretinal PVR membranes, invoking macrophages and RP-derived TGF beta, which induces myofibroblastic differentiation from fibroblasts. So as the RP cells undergo this transdifferentiation from cuboidal to spindle, they begin to express alpha-smooth muscle actin, GFAP, vimentin, and become the main constituent of PVR epiretinal membranes. This is an image, a histology image of epiretinal PVR. You can see how thick it is. It's almost as thick as the retina that is above it. At higher power, you can see that the PVR is composed of this pink material, which is collagen fibers, and there are also these cells on the epiretinal surface next to the hyaloid there, and you've also got these pigmented cells in amongst the pink collagenous tissue. At higher power, you can see that we have these pink curly fibers of collagen. We have some RP cells down over here, and you can see the considerable tractional wrinkling that has occurred to the inner limiting membrane of the retina at high power. These are transdifferentiated RP cells that have lost their melanosomes and become very fibroblast-like, and these cells elaborate collagens type 2, type 1, 2, 3, and 4, as seen in this pink fibrillar material outside the spindle cells. Now, the transdifferentiated RP cells express cytokeratin 7, and you can see the red indicates where there's positive staining, and you can see that where the membrane is up against the vitreous, you can see that you've got lots of red staining, and also lots of red staining in the actual thickness of the collagenous membrane, as highlighted by the yellow arrows in this epiretinal PVR membrane. This is a high-power view of the transdifferentiated RP cells expressing the cytokeratin 7 very strongly, as indicated by the red staining. The RP cells also, as indicated, express smooth muscle actin, and this confers them with considerable contractile properties. Now, subretinal PVR also is a problem in retinal detachment. So the blue arrows indicate over here the presence of a gliotic retina. And we've seen the epiretinal PVR at the bottom over here, but here you have also subretinal PVR, which in its early phase is composed of these eosinophilic or pink beams of tissue scaffolds between which there are these pigmented RP cells. If you do a PA stain, the extracellular matrix that the RP cells elaborate in subretinal PVR is highlighted by pink staining, and you can see the RP cells that are pigmented in between. Like the epiretinal PVR, the subretinal PVR RP cells can be highlighted again by the cytokeratin stain, which shows a lot of cytokeratin staining in amongst the PAS positive subretinal PVR membrane. Again, like epiretinal PVR, the subretinal PVR RP cells also express smooth muscle actin, which also confers upon the cells at this location with considerable contractile properties. Now, glial cells are the other component of the PVR process. Loss in neuronal cells leads to Muller cell hypertrophy and migration into the subretinal space and into the epiretinal space, and these contribute to the subretinal PVR. Loss in neuronal cells leads to Muller cell hypertrophy and hyperplasia, gliosis, and this leads to intraretinal shortening. It is said that gliosis is thought to protect the retina from damage to the retinal neurons further, but the problem is that the Muller cells, as they become hypertrophied and undergo hyperplasia, release pro-inflammatory cytokines that can lead to further neuronal damage, which is a catch-22 situation. Muller cells are a rich source of cytokines, which are involved in cell proliferation, cell migration, chemoattraction, inflammation, and fibrosis, as shown by this slide. So, let's have a look at the histology of gliosis. Now, the top right shows an area of retina that is not affected by PVR, and you can see that you've got these linear processes of the Muller cells spanning the retinal thickness. On the bottom of here is the optic fiber layer where you find the astrocytes, which are also lighting up. The bottom right is intraretinal PVR, and you can see the retina is atrophic compared to the top right image, but you can see that the brown is the positive staining for the GFAP. This shows a lot of GFAP, and this is indicative of intraretinal gliosis from Muller cell proliferation and astrocyte proliferation, which causes the retinal shortening. This is the epiretinal membrane from before, which showed the RP cells. You can also see brown signal over here, which is astroglial cells and migration of Muller cells on the inner surface of the epiretinal PVR membrane over here. This is the higher power of that previous image. Macrophages are the third constituent of the PVR membranes. Now, macrophages arrive due to breakdown of the retinal barrier, causing macrophages to migrate into the subretinal space and into the vitreous. The presence of macrophages in the vitreous is associated with high risk of developing PVR. We know that macrophages are found in PVR tissue histologically, and macrophages also release numerous pro-inflammatory cytokines such as interleukin-6, interferon gamma, and interleukin-6 is derived from macrophages and T cells and leads to the proliferation of fibroblasts and promotes collagen synthesis, and also leads to the proliferation of glial cells. High levels of interleukin-6 have been identified in the vitreous of eyeballs exhibiting PVR. Interferon gamma is also elevated in globes affected by PVR and activates macrophages, and other intracellular signaling pathways are thought to be involved in the pathogenesis of PVR, including the jagged notch pathway, the Wnt beta-catenin pathway, and components of the jagged and notch pathway increase RP cells undergoing EMT and leads to further production of TGF-beta, setting up a very, very vicious positive feedback cycle. Here we have histology of epiretinal PVR. The red is a CD68, which is a marker of tissue macrophages. And this is also in the subretinal PVR, where there are lots of CD68 positive macrophages. at this location as well that confirms that macrophages are also involved, in addition to the glial cells and the RP cells in this particular process. This slide summarizes the various molecules and processes that are involved in PVR, and is a very nice paper from Pasteur et al. This is worth reading because it is an excellent summary of the molecular pathogenesis of this very important fibrotic process that leads to failure of retinal flattening full stop. So in summary, we've covered the basic pathophysiological steps involved in the PVR process. We've covered that there are three main cell types that are implicated: RP cells, glial cells, and macrophages. We've covered the basic histopathology of epiretinal and subretinal PVR, where I showed the presence of transdifferentiated RP cells, the glial cells, the mother cells, and the astroglial cells, and the macrophages. We've covered the very important process of EMT that the RP cells undergo when they detach from Bruch's membrane. We've covered very briefly the roles of cytokines in PVR pathogenesis. And with this, I'd like to thank you for your time, for allowing me to present.
So we will take questions at the end of the session. We have a Q&A box where you can type in your questions and we'll ask the panelists. So for our next talk, we have Dr. Ferenc Kuhn, who needs no introduction. He's literally, you can call him the father or the grandfather of ocular trauma. He was instrumental in developing the very useful BETT scores, the ocular trauma score system. And he has multiple publications, books that we all read and learn from and still learn. And he's a great teacher. And he's basically a vitreoretinal specialist like all of us. And he's a leader in ocular ophthalmia trauma. And we would like to know, he's done a lot of work, and like to know about his experience with prophylactic chororetinectomy for eye injuries with high-risk PVR. So over to Dr. Ferenc Kuhn.
Hello, I am going to discuss the use of prophylactic chorioretinectomy to prevent PVR in high-risk injury cases. PVR is enemy number one for us. But we know that if we know our enemy, we may have a chance to win. So the question is, do we know our enemy? The answer is probably, but not really. We know the risk factors, such as open globe injury with vitreous hemorrhage, inflammation, mixture of blood, vitreous and lens, perforating injury, rupture, and something that is not discussed as much, which is retinal incarceration in the wound, where PVR can start. It can be primary during wound closure, when the surgeon directly incarcerates the retina, which may be prolapsed by the injury or by the surgeon if there is some pressure on the eye during wound closure. You really need only minimal pressure to create such a retinal prolapse. You don't know, probably, how much pressure the eye suffers when a sharp cannula is inserted, and the answer is it's almost 350 millimeters of mercury. So this is what happens during this process. You can cause a secondary retinal incarceration, which occurs after wound closure by the body's response, which is scar formation. Here is what happens in this case. In this instance, it's like an intraocular keloid, and the fibroblast is the most important cell to create this. And finally, there's a tertiary possibility also after the injury, and also the response from the body. In this case, you have injury from the inside to the retinal pigment epithelium, possibly the choroid and the sclera as well. And here is how this process occurs. In this case, the cell most important is the retinal pigment epithelial cells. Here is a clinical example, blood after a foreign body impact, which was deep, involving the RPE, possibly the choroid and the sclera, and this is how the eye ends up. In a perforating injury, you can have direct incarceration of the retina into the exit wound, plus you have a vitreous tract. In cases of a rupture, which goes very posterior in the sclera, involving zone 3, you almost always will create retinal prolapse. If you have a foreign body injury, which is deep impact, again, you have damage to the posterior structures, to the neuroretina. And finally, there is an additional possibility, which I call PVR stage 0, in which case you do not have true PVR, but you have retinal fold formation as the scar captures the retina. So if you look at PVR rates in open globe injury, you can see that in perforating trauma, it can reach up to 92%. If you talk about foreign body injuries, the rate is fairly low, 11%. But this means that you do not make a distinction between injuries with and without retinal impact, deep retinal impact. Because if that's the case, the rate again is very close to 90%. Similarly, in rupture cases, no distinction is made between zones 1 and 2, anterior injuries, in which case you have a roughly 20% PVR rate, as opposed to eyes with a zone 3 injury, where it can reach up to 63%. So overall, in these high-risk cases, the risk is roughly 80%. An additional 10% will be those retinal folds, which are very clearly visible here. How do these form? It's very educational to see this on a piece of cloth. As the scar grabs the tissue, you will have radiating retinal folds. These can cause very severe distortion of vision, even if when you look at the eye, such as this, it doesn't seem to be that severe. However, this is not cellophane, this is not surface traction only. In these cases, you have full thickness retinal folds, and they can reach very, very far from the impact site. So this is a very typical case where you have hand motion vision after the injury. You do a very successful surgery when vision improves, and then the folds again appear, and in which case the visual acuity drops. And it's not only the visual acuity in these eyes, but especially the distortion, which will cause tremendous problems for the patient. So what do we do with PVR cases? Well, treatment has very poor results. And we know that once PVR occurs, you will be married to that patient because the patient will come back for repeat surgeries. It would be ideal to use a pharmaceutical approach, but unfortunately it really doesn't work. There have been many drugs that have been tried and none of them really showed an effect. Methotrexate does show an effect, but we have to understand that it's not going to work in trauma because the administration has to start prior to the injury. So, traditionally, what is it that we do? Well, we address the existing problems, such as the open wound, and then concurrent anterior and posterior segment abnormalities. But unfortunately, this does not really improve the situation. So what we do is wound closure. And then we wait until roughly 10 to 14 days, according to the literature, and then we do our posterior segment reconstruction. But in real life, it is even much later, sometimes 3-4 weeks after the trauma. and this is very ineffective. So we need to change our approach, and that means you need to change two things. One, we need to change the type of intervention, what we do for these eyes, and second, we need to change when we do the intervention. So let's look at this in more detail. The type of intervention. What we should do, instead of treating PVR, we should prevent it. So how can we do that? Again, going back to the primary, secondary, and tertiary incarceration. The first is we have to prevent primary incarceration by the surgeon's needle. And instead of doing the typical, where you enter one edge of the wound and then come out on the other side, we can do a sequential wound closure, going in on one side, as you can see here. And instead of coming out directly from the other side, we do it in two steps, and you hold some instrument to make sure that you do not have prolapse of the tissue, the retina, if it's posterior, into the wound while you are suturing. And that is true as you close a posterior scleral wound. As you can see here, initially you open the conjunctiva only in a smaller area. You close the sclera up to that conjunctival cut, and then you repeat it again more posteriorly, a larger area of conjunctival opening, closing the sclera there, etc., etc. So this is the so-called close as you go technique. So let me try to go a little faster to show you. You open the conjunctiva, you start closing the scleral wound from the limbus, and you go progressively more and more posterior in the sclera. And when you reach the conjunctiva, you open the conjunctiva in a larger area, and then you continue with your sclera sutures. And you do this, and this is the big question, until how far posterior?
It's not working.
You have stopped, I think.
Stopped. Having a small.
Hello, I am going to discuss
But it's not playing after that.
video of showing this. Once the vitreous hemorrhage is removed, you can see the incarcerated incarcerated vitreous there. So you go around the lesion, not inside the lesion, but around with contiguous high energy, 100% diathermy applications. And I don't use laser anymore if it's a posterior lesion where you know that there is no vitreous left. You simply do that, and then of course I always do a laser cerclage in these eyes.
Stopped again.
Sorry.
Good evening.
Hello. Vitreous there. That, and then of course I always do a laser cerclage in these eyes.
It doesn't move beyond that.
There. And if you don't do this, but you do the traditional removal of the foreign body then you laser around the high impact site, and then within a few weeks the patient returns with a retina which is captured in what I prefer, which is a primary comprehensive repair. And between the wound closure and the vitrectomy, if it is again delayed up to 4 days, then you have to use heavy topical corticosteroid therapy. So instead of this, you do this. This is a typical case, wound closure, and then the chorioretinectomy. This is a peripheral lesion, so in this case, you have to do it in a larger area to destroy the cells that would cause the proliferation. And then silicone oil is implanted. You do the laser because we are peripheral. There is vitreous remnant, of course. And then again, when you remove the oil, a couple of months later, you have bare sclera, nothing else. Going this procedure, the expected PVR rate was 80%. In reality, it was only 35%. And it's very important to emphasize that all those PVR cases came from elsewhere in the eye, not from the chorioretinectomy site. And also the 10% expected PVR rate, zero PVR rate dropped to nothing. And this was shown in several series. And you can also do the same prophylactic, non-prophylactic treatment. If you have retinal folds that have developed, you do that and then the folds will disappear. So in summary, the traditional approach doesn't work, and that means you have to change what you do. And you also have to choose the timing properly. So do a primary reconstruction or within 4 days, not later, and do a prophylactic chorioretinectomy in these eyes where the PVR risk is very.
So yes, sorry for the glitch. The video didn't play, but I think we got the gist that he just showed us how to prophylactically remove the source of PVR, that is the RP and the choroid, and isolate it from the wound, the tissues from the wound. So we don't have Dr. Mudhar or Dr. Ferenkun on the chat, but we do have a very erudite specialists. We have panelists. We have Dr. Naresh Yadav he's a consultant in we are surgeon of more than 20 years experience in Nethralaya. And we have Dr. Sangeet Mittal from Third Eye Hospital, Jalandhar. We know he's very famous for his good videos, surgical videos, and I'm sure he will share his knowledge with us. And then we have Rajiv, who's a good friend of mine and an alumni now working in LVP, is a vice chair there. So would like to know from the panelists now that does anybody have any experience with using other than steroids, any other medication that reduces PVR, the risk of PVR in the eyes that we see? I'm not talking about trauma, just routine rheumatologic retinal detachment. Any other medicines other than steroids do we use? And if you're not using, is there any other way of using steroids? For example, most of us use oral steroids, but do we use intraocular steroids or do we use subcutaneous steroids in preparation for surgery? Dr. Sam?
Okay. Thanks, Rajiv. I have used methotrexate, and I've used during the surgery in the drip, put methotrexate, I think 40 milligrams of that. And I've used it as intravitreal injections after the surgery. The drip thing, I don't think that it works very well because I think it washes off very quickly. The injections, they do work sometimes and they don't work sometimes. I'm not, the difference was not that significant. So I can't really say whether it's working or not.
Dr. Sangeet, we do have a talk by Dr. Marco on the very specific drug that you chose to speak
Yes,
about.
yes,
We would like to know his comments, through his video. But what about steroids? Do you, let me ask Dr. Rajiv.
Yeah,
He's
so I don't use steroids to prevent PVR per se, but except for cases like where choroidal detachment is there, where we have shown that giving steroids preoperatively to reduce the inflammation has improved the success rate that way. Other than that, I don't think it is either intravitreal or subtenon. It's not shown much of a result to prevent a PVR from happening. So the only drug which to some extent has shown some results is methotrexate intravitreal, which is what Sangeet was talking about. The only problem with that is you need to keep giving injections almost up to 3 to 4 months or even beyond to see some results. So, and again, it's not like wonder drug, so we are not sure whether what's happening there.
so Dr. Naresh, do you?
I have not really used methotrexate, but just a thought. I was just thinking whether in routine cases of RRD where we are planning vitrectomy, should we try to use external drainage more often so that the inflammatory markers, RP cells, don't come into the vitreous cavity, and as routinely we start using external drainage, I feel that could be one option. I'm not sure, I've not tried, but I think that could be one option in selected cases. And the other is that we could use AMG to cover large breaks. We could physically sort of put AMG there. It could prevent the RP cells coming in contact or coming out of the breaks, and it could sort of localized. These are just thoughts I've not really done, but I like. Sangeet, what do you feel about the drainage?
Yeah, I think the RP cells come from there only.
Yeah.
That is there. So one thing I have seen is like if you are putting oil and if you're putting gas, like if you're putting oil, uh, I've usually seen the PVR process starts around 3 weeks after surgery, around 20-21 days. And I don't know, I've tried in few cases. Uh, if we do early oil removal and wash off the cells at that time and put in gas at that time, will it work or not in the long run? I'm not sure, but I think that just came into my mind.
So, a very similar, when we talk about corectomies, has anybody has an like experience of doing corectomies in severe PVR cases? I mean, we know that when we have severe retinal foreshortening, we already cut the retina. But do we also go and remove the anterior choroid and keep it a bare choroid? I mean, we also are sure of having hypotony secondary to that. But does anybody have a thought on that?
I have used chorioretectomies for trauma, but not for PVR as such. The problem is like larger chorioretinectomies, then there will be always a risk of PAVE syndrome uh, developing after that, which is quite serious problem. We have done smaller chorioretinectomies for trauma, and sometimes I have used it for some tumors also.
Does anybody, Dr. Mahesh had a question. Does anybody have any thoughts on the risk of air embolism with large choroidectomies?
So that is definitely a risk if you're cutting a larger area. Remember still that even there's a possibility of an oil going through the space behind and then coming out later on, having an underfill and all those things. But I remember Professor Kuhn was talking about not like a large retinectomies to prevent retinal PVR process, but a smaller impact areas where there is an impact, and then you recreate a smaller area for retinectomies there. So we have done many, especially for choroidal biopsies and things like this, where we have cut choroidal tissue there, risk is not that high if it is a smaller area.
The first talk had a lot of what do you call molecular biology in it, and it looks like there is a very important molecule TGF-beta which can be inhibited specifically to reduce the risk of EMT, that is epithelial mesenchyme transformation of the RP, thereby trying to reduce the risk of PVR. But I'm not sure. There are some trials running around, but we probably have to ask our colleagues from the US if there is anything which is positive, where we are actually targeting only the molecules that are almost the last step before anything changes for the worse. Because when we give steroids, we are expecting a global reduction in the inflammation, but we're not targeting the right cell, so to speak. So Dr. Marco is there on the call. Would you like to take a call, sir?
Sure. Well, Genentech is developing a medication that blocks interleukin-6 signaling, and I think that could actually turn out to be potentially very usable for treating PVR. I think one of the things, steroids have been tried in clinical trials and have been demonstrated to not be effective in treating PVR. So this is something that's been studied far beyond the clinical experience of any single surgeon. One of the issues that I think continually people fail to recognize in testing different agents for PVR is the issue of pharmacokinetics. Many years ago, Mark Blumenkrantz tried to study the use of anti-cancer agents like 5-fluorouracil in treating PVR. And the reason it failed isn't because 5-fluorouracil in principle wouldn't work. It's because the half-life of the drug is so short that you have to give it repeatedly. And that's true of methotrexate. There have been studies initially reporting the use of intravitreal methotrexate during surgery as being effective, but that's obviously not going to work because the half-life of the drug in the vitreous is about 6 to 8 hours, and PVR is a process that occurs over a period of 6 to 12 weeks. So it just stands to reason, if you think about this from a pharmacological standpoint, that unless you have a drug that has an extremely long half-life, you're going to need to have repeated exposure to any medication. And I would include interleukin-6 inhibitors in this. And I would also include steroids. So when people talk about the use of steroids and how it's failed to work, the reality is, has it actually been tested in a way that makes pharmacokinetic sense? And I think the answer to that is no.
Thank you, Dr. Marco. I think we don't have any more questions from the other panelists, and so we'll go ahead with the next session. So we are actually preponing the last session, which is the session where we have talks from Dr. Marco and Dr. Andrew Chang. So I would like to call Dr. Vinita to moderate the session, please.
Thank you, Dr. Chetan. So we are now having the next session on this fibrosis and retinal detachment and proliferative retinopathy. So I call upon and invite Dr. Marco Zabin to share his experience and give us his insights on his intravitreal methotrexate to prevent proliferative retinopathy. Dr. Marco Zabin has served as the chair of the Institute of Ophthalmology and Visual Science at Rutgers, New Jersey Medical School and Rutgers University for many decades. Now, apart from these, he's also dedicated his time for the ophthalmic trauma services at University Hospital in Newark and New Jersey. So over to you, Dr. Marco Zabin, for your talk. Thank you.
Good. Thank you for giving me an opportunity to speak with you today. I'm going to discuss the use of methotrexate in the management of complex retinal detachment. These are my disclosures. Of note, I was a co-investigator in the GUARD trial sponsored by Aldira Therapeutics. As you all know, methotrexate is a competitive inhibitor of dihydrofolate reductase, and it interferes with DNA synthesis. It's been employed in oncology and rheumatology and in ophthalmology as a steroid-sparing agent for patients that have chronic inflammatory disease. The intravitreal half-life of methotrexate in rabbits is 6 to 8 hours. A number of investigators have reported the effectiveness of methotrexate in treating patients with retinal detachment associated with proliferative vitreoretinopathy. Some of these investigators are listed here. The first to report the use of serial intravitreal methotrexate injections to treat PVR were Dean Elliott and Thomas Strayevsky. The clinical indications for the patients that I'm about to report were those that were used in the GUARD trial. So patients who had a retinal detachment or a recurrent retinal detachment associated with PVR and that had star folds in 3 or more clock hours were offered treatment. Also patients that had a retinal detachment associated with an open globe injury. And of course, finally, the patients were advised ahead of time that they would not only go intraoperative methotrexate injection, but we would attempt to give them 12 postoperative methotrexate injections in the office. The surgical procedure we used was standard. All patients underwent vitrectomy, membrane peeling, laser treatment, silicone oil infusion, and intravitreal injection of 400 micrograms of methotrexate in 0.1 cc's. After surgery, they received 8 weekly methotrexate injections, and after that, they received 4 additional injections every other week, bringing the total number of injections, ideally, to 13. We asked the patients to recline supine for 20 minutes after each injection in order to promote the posterior diffusion of the medication in an attempt to minimize corneal toxicity. The patients also underwent a number of additional procedures, which are listed here, including retinectomy, ruptured globe repair, foreign body removal, cyclitic membrane dissection, choroidal hemorrhage drainage, cyclodialysis cleft repair, crystalline lens removal, and posterior chamber intraocular lens removal. These are the results in all the 21 patients I'm reporting today, and I'd like to go through them systematically with you. The mean age of the patients was 56, ranging from 10 to 87 years. 12 of the 21 patients' eyes had sustained trauma, and of these 12, 10 had sustained open globe injuries. All the patients had PVR, but 12 of the 21 had grade CA PVR, which means that the membranes were present anterior to the equator, and in many cases these were associated with foreshortening of the retina and even dragging of the retina onto the pars plana. And as a result of this, 9 of the patients underwent 360-degree retinectomy. 1 underwent a 300-degree retinectomy, but is not included in this list of 9. The average follow-up was 17 months, with only 2 of the patients having follow-up less than 6 months. The average number of methotrexate injections received was 11, and 81% of the patients received 10 or more injections. The single operation success rate was 90%. Of the 2 failures, 1 was a 9-year.
The video quality is not coming very well. So I think a couple of them had this problem. Let me just. Now it's okay.
Better now.
Thank you for giving me an opportunity to speak with you today.
Now looks fine.
Now looks.
Yeah.
Thank you for giving me an opportunity to speak with you today. I'm going to discuss the use of methotrexate in the management of complex retinal detachment. These are my disclosures. Of note, I was a co-investigator in the GUARD trial sponsored by Aldira Therapeutics. As you all know, methotrexate is a competitive inhibitor of dihydrofolate reductase, and it interferes with DNA synthesis. It's been employed in oncology and rheumatology and in ophthalmology as a steroid-sparing agent for patients that have chronic inflammatory disease. The intravitreal half-life of methotrexate in rabbits is 6 to 8 hours. A number of investigators have reported the effectiveness of methotrexate in
Extremely sorry. I think the video quality is not good. Many of them are telling.
No, actually not.
Dr. Marco, can you directly present it? I think that would be better.
Yeah, I can. I'll just pick up where we left off. I just need to be able to share my screen. Can I do that?
Yeah, please.
I can. Okay, yeah, let me try that. Can you see my screen?
Yeah.
Hold on a sec, excuse me. Let me go here. And let me shorten this. Oops, sorry. Good. You see my screen now?
Yeah.
Good. So I'm going to get to where I was when we lost each other. So the average 81% of the patients had 10 or more injections. 90% single operation anatomic success rate. Of the two failures, one was a 9-year-old boy at the time, and he underwent successful reoperation. The other was a man with presenile dementia who actually was fully attached when I last saw him, but he was lost to follow-up after 3 months, so I counted him as a failure. Now, the most frequent complication, and perhaps the most important one, was the development of corneal epithelial defects, which was observed in about a third of the patients after 4 to 5 injections, which led to a pause in the treatment for about 2 weeks. The average preoperative intraocular pressure is 14 millimeters of mercury, with a quarter of the patients having a pressure of 5 millimeters or less. And the average postoperative intraocular pressure was 12 millimeters of mercury, with 14% of the patients having a pressure of 5 millimeters of mercury or less. At this time, the silicone oil has been removed from 29% of the eyes. I want to illustrate for you a finding of cornea verticillata, which is an early sign of corneal toxicity. It's illustrated in this patient through retroillumination. And if you pause the methotrexate injections, treat the patient with aggressive topical lubrication and sometimes with a bandaged contact lens, the cornea verticillata will reverse, and also the epithelial defect will heal. If you don't take aggressive action, you could end up with a corneal perforation. So you have to monitor and treat aggressively these sorts of issues. Now, the visual acuity results are modest. If we compare the first to the last vision, the first vision on average was hand motions at 2 feet, the last vision finger counting at 1 foot, but it ranged from 1/200 to 2/100 at last follow-up. If we compare the first to the best vision, the best postoperative vision averaged finger counting at 2 feet, again ranging from 1/200 to 2/100. You have to realize many of these patients started out with LP vision, or in some cases, no light perception vision. Overall, though, there's modest improvement in about 76% of the eyes, stable vision in about 14%. One patient ended up with worse vision because of corneal decompensation, and one patient, we never were able to determine the vision because of his presenile dementia, so it's indeterminate. Here's an example of a 62-year-old woman who had metastatic endophthalmitis and underwent treatment, but then developed a retinal detachment with light perception vision. She had a total detachment with PVR, underwent extensive surgery, as you can see here, and ended up with vision of 1/200 and a pressure of 5 after receiving 12 methotrexate injections. She had a corneal epithelial defect, which resolved, and also ended up with hypotony and an epiretinal membrane. Here you can see her preoperative B scan. And here she is at week 7 postoperatively. I hope you can recognize a mild epiretinal membrane in the area centralis. Nasally, she has pretty significant fibrosis at the retinectomy site. But if you look superiorly, temporally, infratemporally, and infranasally, you see something quite different. Minimal fibrosis. It's very flat looking. And you have this stippled RP hyperplasia. This is a very typical appearance of retinectomy margins after methotrexate. Here's another example, a 46-year-old woman who had a chronic retinal detachment with preoperative vision of light perception. She had a total detachment with extensive PVR. She also underwent extensive surgery with a retinectomy. and she ended up 2,400 with a pressure of 11 after 8 methotrexate injections. She also developed a corneal epithelial defect, which resolved and had an epiretinal membrane. Here you can see her preoperative B scan. And here she is at month 3 on the upper right, after surgery. You can see there's significant fibrosis at the temporal margin of the retinectomy. But if you look superior nasally or inferiorly, you again see very little fibrosis, just that stippled RP hyperplasia. The OCTA shows a mild epiretinal membrane, and the B scan shows foveal atrophy. Now, you don't have to use methotrexate to get a good result. This is a 16-year-old boy who I took care of before methotrexate was available, who had a ruptured globe, total retinal detachment, dislocated lens, underwent extensive surgery with a 360-degree retinectomy. He had retinal incarceration in the wound of note. We just heard about that. And here he is on postoperative day 1 with vision of hand motion, silicone oil in his eye. And here he is 6 months later with vision of 2100. And in his case, the retinectomy margin looks really very good. But it's unusual. Typically what we see in extensive trauma cases is what we see here, which is extensive fibrosis at the margin of the retinectomy, often with traction, and not infrequently extension of fibrosis out into the far periphery towards the ora serrata. So in summary, I'm really quite confident that methotrexate reduces scarring at the retinectomy site and increases the chance for a retinal reattachment with a single operation in the setting of retinal detachment with PVR or high risk of PVR. And I emphatically include high risk of PVR, including patients with ruptured globe injuries. In addition, I believe it probably reduces the likelihood of hypotony in severe PVR cases. And in fact, this result was observed in the GUARD trial also. But it can be associated with complications. And I emphasize the corneal complications, which can be managed but must be monitored carefully and treated aggressively. But of course, I caution you that the results I'm showing here are just a retrospective, uncontrolled small study and from a single surgeon. However, I think that the results, because they so closely do mirror the results of the GUARD trial, probably have some external validity. Thank you very much for your attention.
Thank you very much, Dr. Marco, to pitch in and share your experiences live, despite the glitches that we are having. So I would now request Professor Andrew Chang to kindly, since you're present at this late night, I would request you to please give your presentation live, if possible. So Professor Andrew Chang is the head of ophthalmology, Sydney Eye Hospital, and medical director, Sydney Retina Clinic. His commitment to international ophthalmology includes the role of Secretary General of Asia Pacific Vitreoretinal Society and also Deputy Secretary General of Asia Pacific Academy of Ophthalmology. So over to you, Professor Andrew Chang. Thank you.
Thank you very much. So if you give me the control, I can share my screen.
Marco, can you yeah, now you can share it.
Okay, what I'll do is I will see if I can share the video.
Yeah.
Yeah, that might just be easier then.
Perfect.
Is it working? Yeah.
Yeah. You can just play.
Let me just move this and I'll just play.
Yeah.
Good evening. Thank you for inviting me to present on fibrosis in retina detachment. In this talk, I will be talking about some simple concepts to help patients understand retinal scarring and also management and tamponade options in this difficult to treat situation. Proliferative vitreoretinopathy is a condition that many of us face, particularly in treating complex retinal detachment. It is undisciplined scar tissue, and PVR represents a wound healing response. We see it in 5 to 10% of retinal detachment. The risk factors include giant retinal tears, multiple large retinal tears, patients with choroidal detachment, vitreous hemorrhage, trauma, and uveitis. This leads to failure of retina detachment repair. When patients present with a redetachment, it is often devastating and rapid. And I explain to patients that proliferative vitreoretinopathy is when the retina becomes like cling wrap. And what this means is that the retina stiffens. And so I describe the retina like cling wrap on the top of a large bowl. And as it tightens, the retina pulls off, and it is difficult to push the retina back into position along the inside of this large bowl, that is the eyeball. One of the challenges we face is to keep the retina in position. We have now a choice of tamponading agents, including variations of gas, heavy liquid perfluorocarbons, which I'll talk more about, as well as silicone oil, both light and fluorinated heavy oils. Let's talk about liquid perfluorocarbons. These are heavy liquids with a high specific gravity, and the advantage of this is that it can flatten detached retina and displace subretinal fluid. It is clear, so it allows visualization of the retina during surgery. It has moderate surface tension, which allows the liquid to remain cohesive after injection, and it has a low viscosity, which enables surgeons to handle it when injecting and removing the heavy liquid. The aims of PVR surgery is firstly to identify and treat all retinal tears. Then we need to relieve all traction and oppose the retina to the retinal pigment epithelium. Mature preretinal membranes can be peeled with forceps, and heavy liquids are useful in flattening the retina and to identify areas of residual traction and shortening. Step 2 may involve a relaxing retinectomy. So much of PVR is inferior, and this can be managed with scleral buckling to relieve the traction or a relaxing inferior retinectomy. In this instance, heavy liquid is useful as an intraoperative stabilization tool. This is a video of a patient who has an advanced total retinal detachment, which is open funnel. And once the vitreous is removed and trimmed towards the periphery, we can see in this instance an inferior retinal break. Heavy liquid is injected into the eye and it stabilizes the retina. Fluid is moved anteriorly, and under the heavy liquid, areas of shortening and traction can be identified, and membranes can be removed under the heavy liquid. Here it is decided that I will do a inferior relaxing retinectomy, and diathermy is placed in a row. This then allows a retinectomy to be performed with a cutter. And we can see here that the retina has relaxed, and endolaser photocoagulation is performed to the edge of the retinectomy. The next step is to decide on vitreous and retinal tamponade agents. gas and light silicone oils do not tamponade the inferior retina, and heavy fluorinated oils, vitreous substitutes, and also heavy liquid perfluorocarbon tamponade the retina inferiorly very effectively. I'm going to talk now about giant retinal tears, and this was the first surgical indication for liquid perfluorocarbons, and it showed that it effectively allowed us to treat giant retinal tears with high success rate. And we also explored the concept of short-term tamponade, and that is leaving heavy liquid in, which reduces the risk of posterior slippage and potentially reduces the severity of PVR. And supine positioning would have a better patient compliance than face down positioning, as would be the case if we use gas or light silicone oil tamponade. This is a surgical video showing how we traditionally now repair giant retinal tears. And here heavy liquid is used to roll the retina back into position. Endo laser is performed around the edge of the giant retinal tears. The heavy liquid is left inside the eye for several days, usually 5 to 7 days, and then removed. This is a way that we now treat routinely giant retinal tears at the Sydney Eye Hospital. And in a retrospective study of 62 consecutive eyes, which were published some years ago, we showed high success rate. And colleagues also elsewhere in Australia have used a similar technique with similar excellent results. So with experience in treating advanced retinal detachment with giant retinal tears, we now move to PVR, or recurrent retinal detachment with much severe scarring, such as in this case here. So this patient had had multiple surgeries before light silicone oil had been introduced into the eye, and you can see now there is silicone oil under the retina, as well as very severe retinal scarring. If there are areas of mature scarring, as we can see here, it may be possible to peel, and this will loosen the retina. In this case, it was so badly scarred that an inferior relaxing retinectomy was performed. Once the retina is reflected, you can see here that there is light silicone oil underneath the retina, which was removed. And once that is done, the retina becomes more mobile. Heavy liquid is introduced into the eye to tamponade the retina. And this also shows up there is an area of traction which we need to extend the retinectomy, and then endo laser is performed to the edges of the retinectomy. The heavy liquid is left in position for several days and then subsequently exchanged for gas. And this is the ultimate result, much better than we would have initially thought. We also published on our experience with short-term heavy liquid tamponade in primary retinal detachment. And it showed in this study that we were able to reattach the retina in many cases, but in eyes that had SF6 as an exchange on the stage 2, 77% redetached. But ultimately, the anatomic success rate was 92%. There are complications resulting from these techniques, including cataract progression inflammation, as well as macrophage deposition, which we can see on the lens capsule. And about a third of our patients had slightly elevated intraocular pressures, but these were usually able to be managed medically. Once again, thank you very much for inviting me to share some complex cases and how we may manage them using different tamponading agents.
Thank you very much, sir, for a very nice talk. I would like to welcome now our eminent panelists, Dr. Mahesh Shanmugam and Dr. Naresh Babu, sir. So Dr. Mahesh Shanmugam currently heads the Vitreoretinal and Oncology Services, Sankara Eye Hospital, and a co-founder of RetNet India. Above all, he continues to be our guru, as he has trained many a vitreoretinal surgeon for more than 3 decades. So welcome, Dr. Mahesh Shanmugam, sir. And I would also like to welcome Dr. Naresh Babu, who is the Chief of Retinal Vitro Services and a senior consultant from Arvind Eye Hospital, Madurai. He is known to be a very high-volume vitreoretinal surgeon and also has done his MBA with specialization of human resource from Annamalai University. Welcome, Naresh Babu, sir. So we can't hear you, sir.
Thank you, Dr.
Oh,
Netta.
okay. Yeah, unmuted.
Okay. So to begin the discussion, I would like to ask Dr. Marco, sir, as to whether he is routinely using intravitreal methotrexate, and if so, can he just give an insight to his real-time experience?
Yes, thank you for asking. I don't use it in every retinal detachment case. I do not believe that that would be appropriate. I only use it in cases that have significant PVR, which would mean at least 3 clock hours of epiretinal membrane formation, or in cases that are very, very likely to develop PVR. And so those would be ruptured globe injuries with retinal incarceration, or ruptured globe injuries with vitreous hemorrhage and retinal detachment, that sort of thing. And there are a couple of reasons for that. The first is that for the methotrexate to work, you need a number of injections. Now, I'm not arguing that everyone needs 13. In fact, I think at this point I can sort of tell when they're going to need all 13 and when they're not. But you have to see the disease evolve to get a sense for that. If the eye looks very quiet by the 6th injection, often you're going to be able to get away with 8, something like that. But you just don't know that at the beginning. And it's difficult for the patients to come back and get injected every week. And of course, when we're talking about children, that's a whole different issue, because now the child is going to have to undergo gas anesthesia on a weekly basis, and the parents need to understand and really be very motivated to go through that. So definitely, it's not a routine. I would not use it for cases where I'd be doing a buccal or a simple vitrectomy, something like that.
The thing is, has to be a proliferative vitreoretinopathy and above C grade. So I would just wanted to, I think you almost answered my second question as to which is the end point that you see, because do you start off weekly injections anyway when you've already chosen a very severe PVR case? So because of the short half-life is very short, that
it's amazing that it works just with weekly injections, given how short the half-life is. But, the things that make me believe I'm going to need to continue for the full course of injections are the following. If the pressure is low, if the eye looks inflamed, if the media are not crystal clear and quiet, those are the things that tell me that there's an ongoing inflammatory response, and that I need to, as much as I can, push forward with the full course of injections.
Continuing to that same question, sir, in your trial, if I'm right, there were only 14% cases in the postoperative period which had hypotony. That is 3 out of 21. So why only 29% underwent SOR?
I do want to clarify, it wasn't a trial, it was a retrospective
I'm
case.
sorry. I'm sorry.
It's interesting to ask the question. So in some cases, I did not want to remove the oil because the intraocular pressure was borderline normal, say 9, something like that, maybe 8. And I really felt that removing the oil would result in hypotony. And I've seen that happen. In some cases, the patients insisted on not removing the oil because they had been through so much prior to this one operation that, and they were happy with what they had achieved. They didn't want to push it further, and it's sort of I wanted to remove the oil, but they did not want to do it. So I said, fine, as long as their pressure was okay and their cornea was clear, I didn't force the issue. But if it had been the case, I would have insisted that they remove the oil.
Do you think it had anything to do with lesser emulsification? You're using methotrexate? Because if it had emulsified, you would have definitely felt like removing it.
I'm sorry, could you repeat the question, please?
I said, does methotrexate, do you feel have anything to do with lesser emulsification? How much was the emulsification of the oil?
Not very frequent. Look, in 100, if anyone who's taken oil out knows, and I don't think I'm exaggerating, in 99% of cases, when you have the patient lying flat on their back, you'll see tiny emulsified oil droplets, almost universally. But I don't think that's what you're asking me. You're asking me, was there enough emulsification to cause an increase in intraocular pressure or to cause this inverted hypopion? No, I didn't observe that at all. There was no significant emulsification where you could see the floating little bubbles in the superior part of the anterior chamber. That never happened. But you don't need to have that for the oil to create an increase in the intraocular pressure. Of course, it can if it does that, but you can have a pressure rise just from having the oil filling the anterior chamber. Remember, a lot of these eyes are aphakic. So, I hope I've answered your question.
Okay, yes, sir. Thank you. Thank you very much. And I would like to ask a question to Dr. Andrew Changs. So, in which cases do you actually determine you would be using a PFCL for a longer while? And the second question is, does it really help you in cases where you have recurrent retinal detachments after the proliferative vascular retinopathy? Like if you have a diabetic retinopathy, you've operated a combined retinal detachment, and then you land up with a recurrent RD with PVR. So do you think it has helped you in these kind of cases? And if so, can you share your experience?
Yeah. We find it really useful. So I might divide the situation into intraoperatively. So intraoperatively, we find it a very useful stabilization tool. It allows us to reattach the macula and hold the retina, in a very stable situation. And you saw in the video that one could identify areas of traction which might otherwise be hard to see. So epiretinal membrane can be removed if it's more mature and formed, but it's also useful to show us where the retina is shortened. And if we are going to do a retinectomy, we can modulate the extent of the relaxation depending on where the traction is. The variation of heavy liquid is to keep the heavy liquid inside the eye for a period of time, temporary tamponade. In my hands, no more than 5 days. And what this does, it actually stretches the neurosensory retina over time. So sometimes at the end of surgery, and we really do not wish to perform a retinectomy unless absolutely necessary, because it changes the whole dynamics of the detachment. So if you had quite a taut retina, you can either put a buckle on, which we do, but if there's still some shortening, after a week of or 5 days of heavy liquid, it will actually stretch the retina back into position. We now use, in this instance, fluorinated oils denser on, which you find very useful. So in this situation, we take out the heavy liquid after, say, 5 days, and then put in heavy silicone oil to tampen up the retina. And I find it really very useful. The only issue is that these eyes have to be monitored closely for inflammation. So what effectively I believe the heavy liquid is doing is shifting all the inflammatory mediators and pigment cells and macrophages and RP cells anteriorly. So at the end of 5 days, sometimes the anterior segment is a little bit inflamed. The eye looks quite red. And on the operating table, when the heavy liquid is removed, you can see the eye whitens up pretty quickly as all these inflammatory cells are removed. So I do think in theory, although we're not sure, that heavy liquid will stop inflammatory cells from settling on the retina.
Thank you, sir. Dr. Mahesh, sir, I would just like your inputs on the, have you been using, sir, intravitreal methotrexate? And like we have used IVT at the end of RR to just, it helps us to remove the residual fluid, and haven't been giving any extra injections. So what is your experience
I think Dr. Naresh would be the ideal person to answer this because yes, I actually published studies on this. I have been using it very rarely, so I have not used it like how it has been described on a weekly basis. So it's been rather irregularly. I think Dr. Naresh would be the ideal person to answer this question.
Yeah, thank you, sir. Actually, kindly ignore the noise behind. I think we are in Pondicherry, hospital day is going on. That's why the noise behind.
Actually, we can't hear it. We can hear only you, Dr. Naresh.
Yeah,
then it's fine, sir. Then it's fine, actually. No, in the trial we have done, actually, it's a very small number, 21 and 20 cases, 21 in study group and 20 in the control group, where we have injected methotrexate. We had a complete reattachment in 70%, 72% roughly around. And in the rest to 28, we had partial detachment, but all the cases were macula on. Compared to the control group, where almost 35% had detachment with macula off, and 20%, 45% only had a complete reattachment. So we find it very useful in all our cases of what do you call PVR more than C2. And in this trial, we have done the maximum of only 4 injections. And we used to go for early silicone oil removal in most of the cases. But even after the SOR, the redetachment was not great in these cases. So I don't know, we are convinced that it really helps. And we are working on a larger number now. We have a huge number, maybe shortly. And we have recently, okay, that is a different one, yeah.
What is your schedule for the injections, Dr. Naresh?
Sir, at the end of the surgery, first week, second week, third week, sir. At the end of every week, same 0.1, 400 microgram.
So the first 4 weeks you will inject, sir.
Yes.
And then do you increase the duration every 2 weeks or something like that?
No. At the end of every week, first week, second week, third week. Only 3 injections we have done in these cases, but there are people who inject up to 12, 15 also.
If I can ask a question to Dr. Naresh and Dr. Marco, does it decrease the fibrosis, anterior fibrosis, vitreous-based fibrosis, and the anterior vitreous fibrosis, which extends to the ciliary body, particularly in trauma? That's the reason for the hypotony. And even if you dissect, the hypotony doesn't resolve. Does it decrease this fibrous tissue formation, which arises from the penetrating injury?
Yes, that's a very astute question. And actually, someone asked me on the chat a related question. The reason most of our eyes are aphakic is because when I was a fellow, I wrote a paper with Dr. Michaels about the importance of epiciliary dissection to reduce the incidence of hypotony in the setting of PVR. So all of the cases that I'm reporting, I made an attempt to eliminate the epiciliary fibrosis. Now, in the cases that had the cyclitic membrane, I'm sorry the slide wasn't clear in the presentation, but among the various procedures that I did, in addition to reattaching the retina, were cyclitic membrane dissections. And as you probably know, if it's a severe cyclitic membrane, you really can't get rid of all the epiciliary fibrosis. So if those cases are hypotenuse, I can't answer the question. But in the cases where I have removed the epiciliary tissue prior to using methotrexate, I still observed hypotony developing in severe PVR cases, as I think you're mentioning yourself. And that's why I don't know why, but I think the methotrexate does reduce the incidence of hypotony, because I had a much lower incidence in this series, including in the patients with no epiciliary fibrosis, than I would have expected to see given the severity of the disease that I was treating. But I can't offer a rational explanation for it. Maybe the explanation is something like this. If the methotrexate is very profoundly anti-proliferative, if the inflammatory cells can't proliferate, then they can't elaborate as many of the cytokines that are involved in the chronic breakdown of the blood-retinal barrier, which I think underlies the hypotony that we see in the cases where we don't have epiciliary fibrosis. But I'm just speculating. By the way, one of the other variables, so a couple of things are being tried, one of which might be useful for you all in your own clinical practices. How could we reduce the incidence of corneal toxicity? Well, one way would be, as one of your audience mentioned, to try to preserve the lens, if you can do it, either the pseudophakic lens or the crystalline lens. Another way would be perhaps to reduce the dose of methotrexate to 200 micrograms instead of 400 micrograms. So, and in fact, I'd be more inclined to try that than to reduce the number of injections, because of the time course of PVR. It's just a thought, and it's something you might want to try, since I'm sure you have a lot of experience with PVR.
Do we have any other questions?
If I can have a couple of comments.
Yes, sir, please.
Thank you, Dr. Marco and Dr. Andrew, for the beautiful talks. Just a couple of modifications to what Dr. Andrew was mentioning about short-term PFCL. I usually leave the PFCL for about a month now in certain situations. And at the end of the month, I remove it, and you don't have to have any other tamponade. But these are, I'm talking about extremely severe PVR cases or post-traumatic cases where there is or like particularly in children, it's useful, because like children are extremely difficult to make them maintain a prone position. So an inferior break or a supine position is adequate in these children. We can leave them with PFCL. So I think the duration varies. Like Dr. Andrew mentioned, 5 days. I think Dr. Naresh keep it for 1 week. I can keep it for a month and usually do not have an issue. Another area where the short-term PFCL extremely useful is the closed funnel detachments. The closed funnels, the posterior closed funnel, where despite all the dissection, you can attach the retina but throws a lot of folds. So that's something which cannot be ironed out whatever we do. In that situation, once again, leave the PFCL for about a week to 2 weeks without doing laser photocoagulation. That irons out the retina and flattens it. And subsequently, we can take it up and then complete the surgery by doing a laser and then replace the PFCL with oil. A third thing which I've been doing to decrease the risk of PVR is to peel the ILM in these patients, because there will be that immature membranes which are not identifiable. Then if you are able to use stain and then peel the ILM, that kind of gives a handle by which we can peel the immature membrane. That also helps in increasing the chance of reattachment. One final thing is, like, despite all the medication which we use, there is no alternative to doing a proper surgery. So removing all the membranes and removing all the areas of traction is extremely important, maybe with a buckle, maybe with a retinectomy. In addition, we can use methotrexate, but then methotrexate is not an alternative to doing a proper surgery.
That's it. So just
Could
to
I
add that, actually, recently we have published 74 cases of GRT. So our reattachment rate is close to 83%, if I remember correctly. But in all these cases, we have used stage surgery with the PFCL. So PFCL is a wonderful tool, especially in case of GRT, with or without PVR, in completely stretching out the retina and preventing the slippage of the retina, and in a very good reattachment rather than in a single stage. So PFCL short term is a wonderful tool for GRT part.
Could I ask a question? I'm just for my own education. What's the longest that you've left the PFC in the eye without complications?
Incidentally, I have had to leave the PFCL in a patient where the patient was lost to follow nearly more than a year, 2 years.
Yes.
So you can see bubbles of PFCL in the anterior chamber, but like nothing dramatic has happened. It's not as though the corneal endothelium went for a toss or anything like that. But then it's like for more than a year also, incidentally, I have had to leave because the patient did not come back for a follow-up and nothing serious happened. But there have been instances, as I think Dr. Chang mentioned, 20% of the patients may develop inflammation. So which the 20% is we can't make out. So these patients have this fine feathery deposits on the surface of the retina, which kind of come off when we remove the PFCL, but that's an inflammation which some patients develop. But a mixture of a PFCL, oil, and viscoelastic actually is very, very potentially kind of a dangerous gooey mass it forms. That becomes extremely difficult to remove. So incidentally, if you leave behind a little bit of viscoelastic, oil, and perfluorocarbon, that can form a gooey mixture that becomes extremely difficult to remove.
The
Thank you.
did in 21 days, sir, actually. For PFCL in animal models, they have kept for 21 days without any damage. But in practice, even a longer doesn't really cause any problem.
Got it. So good. I'm glad to learn that. So somewhere between 5 days and a month sounds perfectly okay.
So can I just make a comment about that?
Please, sir.
Yeah. So maybe it depends principally on the age of the patient, or whether there's inflammation, or whether you've actually made a large retinectomy. But as Mahesh said, there are inflammatory clumping on the retina and also usually on the back of the lens, and it can't really be removed intraoperatively, but goes away quite quickly. I've also had patients where the heavy liquid's been left in.
Then we'll sit after that and do it.
And the real fear about these cases are the loss to follow-up. So that's the real watch out for these cases. And so if a patient disappears or and doesn't come back, it can actually cause quite a lot of inflammation, which we can't monitor. And I have left it in actually for up to a month, and the eyes are fine. But I would say, just as a rough ballpark, you start to see inflammation usually at around about 5 to 7 days. If you look carefully, there's just this fine KP. I think of it like KP on the back of the lens. And I do think it probably relates to agitation of the eye, like oil emulsifies with shaking of the eye. And because you're telling people that they don't need to look face down and that they can do what they want with an inferior tamponade, they just run around completely normally, and they might be younger patients. Just a few comments, but it's a wonderful tool, and we've been using temporary tamponade for a while, and I'm not sure, Marco, in the US, whether this is now. Initially it wasn't, so.
Yeah, no, it's not typical, but I was very impressed to hear how you could get the folding to sort of unwrinkle with it. And I think that could really be very useful
It's quite amazing. So you'll see this tightness as you laser posteriorly, but there's a shallow fluid.
Yes.
Anteriorly, it stretches out.
Yeah.
And then you do a little bit more laser, and then we put in denser on in these cases.
Yeah, very helpful.
Thank you very much.
Can I have a question to Dr. Mahesh?
Yes, sir.
Because we see that most of the PVR, especially where we do the retinectomy, is at the edge of the retinectomy in the periphery. So how does an ILM peel, which is probably within the arcade, actually reduce the risk of PVR?
Well, I'm not saying that reduce the risk of PVR. What happens is like the immature PVR, we are not able to identify the membrane. Mature PVR, you can see these nodes where we can identify and peel. But sometimes you know that there is a fine wrinkling of the retina, but you're not able to identify where to start peeling. So in that situation, when you start the peel with the ILM, once it's beyond the arcade, you can see that like it kind of gives you an indication where the second membrane is, or where the immature PVR is, and helps us to peel. It doesn't decrease the PVR incidence at the edge of the retinectomy, but the posterior PVR, the immature PVR, is where you peel the ILM, and it helps. It's kind of acts as a handle to identify the immature membrane.
Okay, thank you.
Thank you, sir. Thank you, everyone, for a very interactive session. I will now call upon Dr. Girish Rao, sir, to moderate the next session.
Yeah. So I think we are at the last leg of this fibrosis, and I'm thankful for people who have stayed on online here. So let's start with the first presentation by Dr. Chetan, who will be talking to us on the OCT characteristics of ERM. Dr. Chetan is a senior consultant at Nethralaya, and he has special interests in imaging, especially OCT and in ROP surgeries. So over to you, Chetan.
Good evening, and thanks to Dr. Rajiv for this opportunity. I'm going to discuss the optical coherence tomography characteristics in epiretinal membrane. Epiretinal membrane has been variously called as surface wrinkling retinopathy, macular pucker, preretinal fibrosis, or cellophane maculopathy, often describing the appearance on the fundus examination. Histopathologically, it is a tissue composed of collagen layers and cells with contractile property, namely myofibroblasts. Before we delve into the effect of epiretinal membrane on the retinal architecture, it is important to learn the anatomy of the fovea, especially the central bouquet that has a bearing on the pathological changes from traction. The central bouquet, or the Rochon-Duvigny bouquet, is a small, less than 100 micrometer island of around 2000 thin cone photoreceptors in the central fovea, crucial to its architecture and vulnerable to mechanical stress in vitreomacular disorders. There are two models describing the Mueller cell distribution, which is the principal foundation of the foveal pit, and one model describes it as parafoveal Mueller cells extending from the interlimiting membrane to the foveal cones, and the other model talks about a unique population of Mueller cell cones which are directly in the center of the foveal pit. In both the models, however, traction on the inner surface of the retina is transmitted via the Mueller cell to the foveal cones, causing damage. So there are primarily two types of epiretinal membrane: the idiopathic epiretinal membrane, which develops consequent to the posterior vitreous detachment, and a secondary RM that develops due to the various intraocular pathologies. I'll be describing the idiopathic variety on OCT. There are two popular theories of ERM formation. During PVD, in areas of strong vitreoretinal adhesions, the ILM is cleaved, and it has been shown histopathologically, especially in the areas of retinal vessels where the ILM is thin, the cleavage occurs. The retinal glasses then proliferate through the cleavage points onto the retinal surface and form an ERM. The other hypothesis is that due to the residual vitreous cortex, which contains the hyocytes left behind on the surface of the retina after a posterior vitreous detachment, allows the hyocytes to proliferate and form an ERM. So on the left hand side, you can see electron microscope picture of the retinal surface after a PVD, which contains no vitreous elements and appears like a smooth membrane, whereas on the right hand side you can see vitreous cortex remnants in the form of disc or an outline around the perifovea. The residual vitreous cortex following vitreosis contains hyocytes, which in the presence of cytokines like the basic fibroblast growth factor, nerve growth factor, proliferates and differentiates into a myofibroblast. However, cells other than glial cells like the RP, fibrocytes, macrophages, etc., undergo differentiation into actin filament containing spindle-shaped cells called the myofibroblasts that have contractile property. And in the secondary ERM, the development of ERM is potentiated by the oxidative stress and the inflammation. So what are the anatomical changes that you see when you have an epiretinal membrane? On slit-line biomicroscopy, the early ERMs appear like a sheen on the macula. They can be just surface wrinkling. As the ERM progresses, it causes distortion of the macular vessels and ileum striae. It becomes opaque when you can actually see the membrane, and sometimes you get a pseudo-hole appearance as you see in the picture on the left-hand side. And very rarely you can have punctate hemorrhages or lipid deposits at the edges, suggestive of increase in the traction. Patients with the epiretinal membrane usually have no symptoms. Rarely they present to clinic with metamorphopsia or insidious vision loss. I'll be describing some important OCT characteristics of epiretinal membrane that have clinical relevance for prognosis and surgical decision making, namely vitreoretinal interface changes leading to ectopic inner foveal layers, EIFL, macular pseudo-hole, tractional lamellar hole, degenerative lamellar hole, cotton ball sign, foveal crack sign. So before we delve into the lesion types, it's important to know the natural history of epiretinal membrane and the prognosis for vision. The Blue Mountain Eye study, a 5-year-old population-based assessment of epiretinal membrane was done, which showed that almost 75% of patients had a stable visual acuity with an ERM. Bion et al. Studied a cohort of idiopathic ERMs with good visual acuity over a period of 2 years, and they found that the visual acuity remained stable when the epiretinal membrane was of a global attachment type. However, just over 1/3 of the patients with the global attachment type, which is assumed to be an early stage ERM, in a 2-year period will turn into a morphology called the partial attachment that starts affecting the vision, and some of them will turn into a pseudo-hole, which is a benign form of the epiretinal membrane. Andrea Govit et al. Hypothesized that the ERM exerts tangential traction on the inner retinal surface and studied the OCT changes and its vision correlation. They described a 4-staged evolution of the epiretinal membrane. In the first stage, there is the presence of the foveal pit and well-defined retinal layers. In stage 2, the foveal pit is absent and the retinal layers are still well-defined. In stage 3, there is absence of the foveal pit, well-defined retinal layers can be still seen, but there is presence of ectopic inner foveal layers. And in stage 4, there is absence of the foveal pit, disrupted retinal layers, and presence of the ectopic inner foveal layers. They believe that the epiretinal membrane causes chronic anteroposterior and centropetal traction, inducing the displacement and reorganization of the inner retinal layers, creating a continuous flow of inner retinal tissue extending from the inner nuclear layer to the inner plexiform layer, as shown in the bracket, across the central fovea, and it is referred to as ectopic inner foveal layers. As you can see in the table, in the later stages of epiretinal membrane with the EIFL, the retinal thickness increases and the visual acuity actually drops over a period of time. Gonzalez et al. Studied the visual outcomes in cases with EIFL. They found that when surgery was done for stage 2 EIFL ERMs, 70.8% of them improved to stage 1 with improvement in visual acuity. As you can see in the graph, more than 90% of patients gained visual acuity of above 20/40. However, when surgery is done for stage 3 or 4, the visual acuity does not improve. Less than 6% of patients develop more than 20/40 vision, and the retinal architecture does not get better. Clinicians should therefore have very guarded optimism with regards to surgery for stage 3 or stage 4 EIFL. Here is a 27-year-old female who has vision loss since 2 years. Her visual acuity is 6/24 at presentation. She has a stage 4 EIFL. Vitrectomy and epiretinal membrane removal was done. 1 week later, you can see a residual edema, and a year later, her vision is improved to 6/12, but the foveal architecture is not recovered. There is persistence of cystic spaces in the inner nuclear layer and a preserved ellipsoid zone, which probably explains the 6/12 vision. So here is another case of idiopathic epiretinal membrane in a 15-year-old male child who had stage 4 epiretinal membrane, and though over 1 year the retinal thickness is reduced but the visual acuity remained the same, you can actually see that the ellipsoid zone is still preserved. It is possible that the earlier age of presentation may affect the visual prognosis due to subclinical degenerative changes in the inner retina. Next, we will discuss the cotton ball sign. Sonoda et al. Described a high reflective clump or like reflectivity in the fovea located between the ISOS junction and the COS lines in 63.8% of the ERM cohort, and this homogeneous hyperreflective clump was termed as cotton ball sign because of its appearance. So in 50% of cases where the epiretinal membrane was removed, the corneal ball sign disappears after 6 months. They argued that the cases of complete disappearance also showed recovery of the foveal contour and had a reduced foveal thickness. They postulated that this outcome can be partly explained due to the release of the foveal traction. Hyperreflectivity is possibly due to the cone outer segment distortion or misalignment, making them hyperreflective. However, could it also be a sign of impending vision loss, warranting a cautious approach? A 60-year-old man has 6x6 vision with no vision complaints. He has corneal ball sign at this visit compared to the OCT done 2 years back. The central submacular thickness has increased, suggesting an increase in traction. Coming back to the clinical relevance of the central bouquet, Govetto et al. Studied the traction due to epithelial membrane on the central bouquet over a period of 2 years. They found that the corneal ball sign was the earliest sign of traction on the central cones, followed by development of foveal detachment and SRF, then to development of vitiliform deposits with the loss of ellipsoid zone but preserved external limiting membrane, and finally to advanced stages where the vitiliform deposits migrate vertically upwards, suggestive of extreme damage to the foveal cones. They concluded that the corneal ball sign, foveal detachment and acquired vitiliform lesion may represent progressive stages of the same condition, and as the central bouquet abnormality widens, the visual acuity declines. They found that the EIFL may protect against tractional central bouquet abnormalities, and the foveal Mueller cells likely transmit mechanical forces to foveal cones, contributing to the central bouquet abnormalities. On the contrary, corneal ball sign could also be a transient phenomenon. A 60-year-old male presented with epiretinal membrane and pseudohole with 6/5/15 visual acuity, which has been noted for the past 6 months. So he underwent vitrectomy with epiretinal membrane removal along with ILM peeling and cataract surgery. Visual acuity improved to 6/9 after 6 weeks, but you can see a corneal ball sign and some inner nuclear cysts. The retinal edema has reduced, and you can see a hyperreflectivity at the center of the fovea in the OCT en face. 6 months later, the visual acuity remains stable. There is a developing foveal pit. The foveal thickness is reduced. 2 years after surgery, his visual acuity is 6/9, but he complains of mild distortion of vision for distance, and the OCT shows the corneal ball sign, and the en face OCT at the level of ellipsoid zone shows a hyperreflectivity corresponding to the corneal ball sign. On close examination of the OCT, you can see hyperreflective lines, vertical lines on the right hand side of the fovea right next to the corneal ball sign, which could be visible glial cells due to activation by inflammation, and presence of epithelial proliferation on the left hand side of the fovea. So the corneal ball sign could still be a transient phenomena secondary to a recurrence of inflammation in the central bouquet. Another sign that is described is a foveal crack sign by Ishibashi et al., and they found it in cases of post-RD repair, and it is a hyperreflective line, vertical line in the center of the fovea. They attribute it to parafoveal ERM and have seen it before the development of a macular hole. This sign was found more than 250 days after pars plana vitrectomy for fragmentogenous retinal detachment. The mean interval of development of foveal crack sign to a macular hole was around 232 days. It was not seen in cases which had ILM peeling in the first surgery. So they concluded that the ILM peeling reduces the rate of secondary ERM formation and may reduce the risk of developing a macular hole later on. So periodic monitoring is necessary if you find a foveal crack sign along with an epithelial membrane in post-RD surgeries. Another sign is a macular pseudohole, which is a benign effect of ERM. ERM causes a deepening of the foveal umbo and gives a false appearance of a macular hole. Vision is good and stable, and all the foveal layers are intact. So another sign is a tractional lamellar hole due to ERM. It has a mustache-like appearance, and there is a schisis and a split at the OPL and the ONL levels in the presence of an epithelial membrane. However, all the outer retinal layers are intact, and the vision is normal and stable over a long period of time. This is another example of the tractional lamellar hole. There are differential pathologies that mimic epithelial membrane and related traction changes. There is vitroschisis with thickening of the posterior cortex and a VMT, and appears like a epithelial membrane because of its obesity. There is another entity called the degenerative lamellar hole, which is non-tractional in nature, characterized by a top hat appearance because of the central retinal bump and the loss of ellipsoid layer leading to poor vision, presence of epithelial proliferation and rounded edged intraretinal cavitation. This is another examples of epithelial proliferation with degenerative tissue loss at the macula. In summary, epiretinal membrane has specific OCT characteristics. OCT is helped in characterizing the anatomical changes in the inner retina and the outer retina due to traction. Features like ectopic inner foveal layers and cotton ball sign have been associated with poor visual prognosis in the long term. Can machine learning aid in predicting the presence of epiretinal membrane? It's quite possible because the epiretinal membrane is easily diagnosed and has a characteristic fundus appearance on the fundus cameras and has well-defined OCT features. So Choi et al. Used a generative AI to predict epiretinal membrane from fundus images, and they found the ROC to be 0.9, having high sensitivity almost 92% and specificity of 80%. Jin et al. Developed a deep learning model for predicting epiretinal membrane stages according to the Govetto classification, and it found an accuracy of 87%, which is equivalent to the retina specialist who classified the epiretinal membrane according to stages. And they predict that the model can be used to classify the epiretinal membrane and help in deciding treatment. So in the future, high resolution OCT may lead to newer features of epiretinal membrane and its longitudinal changes. Deep learning models will accurately guide the clinician for surgical intervention and predict the visual and anatomical prognosis for surgery for epiretinal membrane. Thank you for patient listening.
Thank you, Chetan, and I call upon Dr. Lingam Gopal to present his talk on managing secondary ERNs. Dr. Gopal needs no introduction. He was the former chairman of Sankara Nethralaya, the former head of the department at Sankara Nethralaya, and he is the last word in retina in this part of the world. So over to you, sir.
Dear friends, at the outset, I would like to thank Dr. Rajiv Raman for this opportunity to participate in this webinar. The topic allotted to me is management of secondary epiretinal membranes. Other than idiopathic Dear friends, at the outset, I would like to thank Dr. Rajiv Raman for this opportunity to participate in this webinar. The topic allotted to me is management of secondary epiretinal membranes. Other than idiopathic epiretinal membranes, membranes can form across the macula secondary to various disorders such as diabetic retinopathy, vein occlusions, etc., which are vascular disorders of the retina. Membrane can also occur after retinal break formation, and post-retinal detachment surgery, membranes can occur even with successful reattachment of retina. ERMs can also form secondary to inflammatory disorders of the eye following trauma, especially of the penetrating variety, and associated with some of the tumors. We will discuss some of these details in this presentation. Epiretinal membrane is a glial fibrillic acid protein positive, gliotic and fibrous scar containing types 1, 3 and 5 collagen. They contain myofibroblasts and fibroblasts which have occurred by transdifferentiation from the Mueller cells. And it is presence of these myofibroblasts that gives them contractile nature, which results in the retinal distortion causing metamorphopsia, thickened retina and a drop in the visual acuity. In a study, they found that epiretinal membranes which have dense cellular proliferation pose greater difficulty in removing the ILM, the epiretinal membrane, compared to those with less dense cellular proliferation. The importance of internal limiting membrane in the overall management of epiretinal membrane cannot be overstressed. One, histopathological studies of removed epiretinal membranes have shown patches of ILM attached to it, and histopathology of removed internal limiting membrane have shown patches of epiretinal membrane attached to it, indicating that when epiretinal membrane is removed, we can leave behind residues of the ERM on the ILM, as well as tear off the ILM at patches. Hence, removal of the internal limiting membrane along with epiretinal membrane or after the ERM is removed is a good way of reducing the risk of recurrence of epiretinal membranes. Epiretinal membranes formed by retinal breaks have been found to be different compared to idiopathic epiretinal membranes in various ways. They tend to occur in younger population and especially in myopes where the axial length of the eye is longer. They tend to be more symptomatic in terms of metamorphopsia. The membranes tend to be eccentric and are turbid compared to the idiopathic ERMs. The central macular thickness is also more with these membranes compared to idiopathic variety. Coming to post-retinal detachment scenario, epiretinal membranes are not uncommon in the macular area even after successfully reattaching the retina, be it with scleral buckling procedure or a vitreoretinal procedure. These membranes can be considered as limited PVR and they extend sometimes minimally to an extensive sheet that's going all the way beyond the arcades. The visible part of the epiretinal membrane can be small, but as we lift up the membrane, we find that it is extending quite far beyond. These membranes mostly are opalescent. In the milieu of silicon oil, we find often that epiretinal membranes are present like what we discussed just before, but there are also a different kind of membranes that are found in a silicon oil filled eye. These are creamy colored and impregnated with very fine emulsified oil. These tend to be flimsy and tend to shred with forceps. Suction applied by flute needle is a better way of removing these membranes totally. In the milieu of diabetic retinopathy, we find that the membranes across the retina have significant vascularity. Since this is a fibrovascular proliferation that has occurred in response to the VEGF secretion caused by the ischemia of the retina, these membranes tend to be multi-layered, extending across the arcades and macula. However, in the milieu of background diabetic retinopathy, with no proliferative disease present, there can be epiretinal membranes in the macula similar to the idiopathic ERMs. However, when these are present with diabetic macular edema, the management of macular edema can be difficult. So there are cases where there is a coexistence of epiretinal membrane and a macular edema with no PDR, wherein anti-VEGF alone can sometimes resolve the edema. Just as in eyes without epiretinal membrane, there is a need for re-injection of anti-VEGF drugs, but perhaps with no more frequency than if ERM was not present. Hence, a trial of anti-VEGF should be done in eyes with ERM and macular edema before resorting to vitreoretinal surgery. In diabetic tractional retinal detachments caused by the fibrovascular proliferations, surgery is very often indicated when the macula is detached. These are eyes where the retina is ischemic and hence becomes thin and atrophic. Removal of the membrane by peeling would result in retinal break formation and hence a meticulous dissection using preferably a bimanual surgery is required to carefully remove the membranes without damaging the underlying retina. Closed blades of the scissors can be used to separate the loose attachments like is shown in this video, while stronger attachments are cut with the scissors after defining them. Meticulous dissection of all the fibrovascular tissue of the retina is required for not only reattaching the retina properly, but to reduce the risk of recurrence of the fibrovascular proliferation. Since this fibrovascular tissue is vascular, after cutting all the tissue, there will be expected bleeding intraoperatively. Hence, one of the most important part of the surgery is to remove the blood clots following successful removal of the fibrovascular tissue. If the retina was not torn during this procedure or already had retinal breaks before the surgery, then there is no need for fluid air exchange, while if there is a break formation, fluid air exchange is performed along with endolaser to fix the retina. Post-diabetic vitrectomy, epiretinal membranes formation is not infrequent. In a study by Xu et al., they found that the increased risk of ERM was found following vitrectomy for diabetic disease when there is active proliferative diabetic retinopathy at the time of surgery. There is higher grade of fibrovascular proliferation. There is occurrence of post-vitrectomy hemorrhage, and there is residual fibrovascular tissue left behind following the vitreoretinal procedure. Most of these membranes occur within the first 1 year after surgery, and they can be sometimes significant and widespread, connecting with retinal vessels and all the points from which the original tissue was dissected. Hence, resurgery could sometimes be as difficult as the first surgery. The histopathology shows vascular endothelium in most of these recurrent membranes, and following even a second removal, a recurrence is not uncommon. Coming to inflammatory diseases, in a publication by Lanetti et al., they have shown that the thickness of the epiretinal membrane correlates roughly with the duration of uveitis and the duration of epiretinal membrane. And during the follow-up, after finding an ERM in the macula, they found that thickness tends to increase, and this thickness increase is associated with male gender, posterior uveitis, longer duration of uveitis, and where the epiretinal membrane is attached broadly rather than at a focal point. The visual recovery following removal of these membranes also correlates with male gender and a focal attachment. There is a negative correlation with disruption of ellipsoid zone and a thicker macula. There is also a negative correlation with a pre-existing macular damage caused by uveitis. In this video of a cataract and epiretinal membrane formation secondary to uveitis, it's managed first by phacoemulsification IOL implantation. Then a vitrectomy is performed. As you can see, there's fibrinous vitreous in the macular area, premacular area. An attempt was made to detach the vitreous, but it could not be detached all around the posterior pole. The ILM was stained, and ILM was first removed around the thick epimacular proliferation, and then gradually the ILM and ERM combinedly was peeled around the macula because it was found the membrane was strongly attached to the macular area. Once it is loosed all around, the membrane got separated automatically from the foveal attachment. One can see the fibrotic scar in the macular area to which the fibrovascular tissue, to which the epiretinal membrane was adherent. Following this, the posterior vitreous could be more successfully detached in the posterior pole all the way up to the periphery. This is the preoperative and postoperative picture and OCT of this same patient. The left pictures show a hazy media due to both cataract and vitreous debris, and the OCT shows correspondingly a very thick epimacular proliferation with grossly thickened macula. Following surgery, the macula has become compact, although the fibrous plaque is seen in the fovea that restricted the visual recovery. This is a video of a vitrectomy done for epiretinal membrane removal in a case of a combined hematoma in a young child. Being a young child, the vitreous is not detached easily, and hence the forceps is used to peel the fibrils from the disc margin, and after sufficient number of fibrils were peeled off, the cutter is used next to detach the hyaloid successfully from the posterior pole. Then ILM was stained, and careful removal of the ILM and ERM complex was done around the macular area. The membranes tend to be very sticky and attached strongly to the fovea, and hence peeling it across the fovea could be sometimes dangerous. Once the membrane has become loose, even the separation from the fovea becomes easier, and once the membrane is removed across the macular area, the ILM is peeled a little more beyond and the surgery is completed. I would like to end this talk by talking about spontaneous peeling of epiretinal membrane, which if it happens is good both for the surgeon and the patient. However, spontaneous peeling of epiretinal membranes occur rarely in idiopathic membranes, but has also been reported occasionally with combined hematomas. It almost never happens in secondary membranes, although there are a few diabetics where there is epiretinal membrane which is causing traction on the macula, but once the posterior vitreous detaches, the membrane got pulled off and the macula actually became compact without needing any further surgical intervention. So spontaneous peeling of epiretinal membrane leads to restoration of the foveal anatomy as is seen in this OCT. So in conclusion, epiretinal membranes secondary to identifiable disorders are heterogeneous entities. The variables include not only the etiological factor, but also the cellular content, the extent of membranes, and the presence or absence of vascularity. It is also possible anchorage and integration with the underlying structures at locations such as in post-inflammatory disorder where the membranes can be strongly attached to a chorioretinal scar. A Taxocara scar, for example, can have a strong membrane, and if one attempts to peel the membrane across the chorioretinal scar, it will result in a retinal break formation. And hence the membrane is peeled around the scar and it is trimmed down. Often the removal of epiretinal membrane is only a part of the overall management. The ease of removal depends upon tightness of adhesion, the retinal architecture that can withstand the peeling process, and if it does not, one has to resort to a scissors dissection. The absence of vascularity obviously makes the surgery far more easier. Reducing recurrent fibrosis is possible by completely removing all abnormal tissue and possibly by ILM peeling. Thank you very much for your attention.
Thank you, sir, and thank you, Chetan, for the very lucid description of the ERM as well as the management of the secondary membranes. Rajiv, I just wanted to confirm, is Dr. Gopal there online?
Yes, I will hear.
Yeah. Good evening, sir. I know you have had a long day with a late surgery. So Chetan, I just wanted to ask you a question, and that is, do you think advances in OCT technology like a SWIP source or an OCT angiography have actually helped us understand and manage the epiretinal membranes better?
Yeah, so if you look at the current generation of not only SWEP source, but even the spectral domain OCTs, we have, if you can see the picture that I showed were of spectral domain OCT, the Zeiss spectral domain OCT, but many of the publications actually show the Heidelberg OCT pictures there, which are high resolution. So you can still make out all these features very well on that, and it's almost mimicking the histopathology. So we really, what we used to read in Gass's atlas of the histopathology of these tissues, we're actually seeing it now live on an OCT, and the OCT doesn't give just the macula, it's giving far beyond the macula. So for example, if you had to look for anomalous PVD in a myopia, for example, you can actually trace the hilar attachments into the mid periphery in the wide field OCT. So OCT is definitely a boon, and it has become very commonplace to diagnose and manage these disorders on the basis of OCT alone, not just the visual acuity and the symptoms of the patient. So we can actually predict that you are going to lose vision with this disease in this stage, and it's better to operate, and it's good to show the patients the disease progression.
If I can add to what he said.
Yes, sir.
Without OCT, I don't think you can really diagnose ERM in a significant number of cases. In many cases, of course, clinically you can appreciate it, but subtle membranes can be easily missed, except for the fine glistening reflex. Very often, you may actually miss it in the presence of a little bit of cataract. You may not be able to appreciate it at all. But with OCT, we are 100% sure of what we are dealing with.
Yeah. But Chetan, just an extension of the question, do you feel OCT angiography has added any advantage?
So I didn't mention the studies where they did the, the same group which described the stages of ERM also did simultaneous OCTA. So they didn't find any abnormal vasculature. All they did was the epiretinal membrane actually causes a distortion and brings the vasculature closer to this epicenter. So you can actually see the foveal avascular zone not distorted in such, but they've compared that to the foveal plana. So when you see a foveal plana cases, you see the foveal avascular zone is completely abnormal. I mean, you see vessels crossing the horizontal meridian. Whereas in the OCTA for epiretinal membranes, you don't actually see the membranes crossing the meridian unless it's really badly segmented. But if you look at the segmentation and do a good OCTA of the inner retina, you can still see the contraction of the vessels in the superficial plexus, but they don't really cross the horizontal meridian. If its architecture is so distorted, you're obviously not going to get a good segmentation itself.
So I had a question for Dr. LG sir. So do you feel that OCD angiography has any role in the secondary membranes? We know they probably do not add much to the idiopathic membranes, but in secondary membranes where there is some vascularity, would you prefer that as the preferred OCD of choice?
Yeah, yes and no, in the sense, if you find macular ischemia, which can be identified on OCT angiogram, does it influence our decision to operate or not? Usually not. We know that most diabetics who have had advanced fibrivascular proliferation, TRD and all, will definitely have some amount of macular ischemia. Is it in form of enlarged FAZ or frank macular ischemia as well? But that doesn't stop us from operating because they do require still some amount of vision, if not very fine vision. So it doesn't influence the surgical decision, but yes, it's good to know whether there's macular ischemia or not, just to prognosticate the patient.
Thank you, sir. So we have eminent panelists, Dr. Pramod Bende, who is the head of the Department of Vitreoretinal Services at Sankara Nethralaya, and Dr. Lalit Verma, the former president of All India Ophthalmic Society and ex-All India Institute of Medical Sciences faculty. So if I may ask Dr. Pramod, are there any specific OCT patterns that suggest a higher risk of post-surgical complications, such as a macular hole formation? And I also saw you had raised your hand once. So if you have any comment for the previous question.
Yeah, basically, thank you very much for having me here. Like a question for a Chetan was basically what I feel. With diagnosis point of view, most of the time is a clinical diagnosis, except subtle membrane, what Dr. LG said. And most of those eyes, probably vision is reasonably good and we may not take for surgery. But OCT pattern definitely not as a diagnosis, but prognostic point of view is very, very important. What distortions, what Chetan had shown in earlier, and retinal architecture which distort, probably that will have significant prognostic implication, as Chetan has already mentioned. And while before taking patient for surgery, I think it's important if you discuss with the patients and counseling, I think have a paramount important. Definitely that will add the age, which previously we never used table only. Previously we had a FFA. Probably we used to think like if there is a leakage on fluorescent angiography, those are the eyes we knew probably have a reasonable, relatively poorer prognosis as compared to those are not having a leakage on FFA. But this OCT definitely adds this information to us while discussing to the patient.
So regarding the question on, are there any specific OCT patterns which can predict us that these patients are at a higher risk of post-surgical complications like a macular hole formation?
Yeah, of course, we have a thinned out fovea, like particularly added vitreous. It's a combination. I think rather I would say it's a vitreoretinal interface with ERM and having an amount of traction where thin out fovea significantly pulled there and thinning and already probably having an outer layer hole. Those you can just typically can pick up on OCT and may increase the risk of having a, like you have to, probably you need extra care while dealing with these eyes, and the way you peel the, induce the PVD and probably peel the membranes off. So I think that's what we'll have to look into it usually. Thicker membrane, obviously, and again, you have to be a little bit careful. If you have a dentate process with a retinized peel, like a crumpled up, probably you get a better cleavage than having a flat membrane, which is like a global attachment, what Chetan used the word. I think probably those will make it a little bit more difficult to getting the age, and you have to be a little bit extra careful. Those are basically practical issues again.
So if I may have a question for Dr. Lalit Verma. So Dr. LG has...
Is he online? I'm not sure he's online.
Okay. So then maybe I'll have a question to Dr. LG himself. Which are the cases of epiretinal membrane surgery where you would go with a primary ILM peel itself, or is it a decision that you take intra?
In most membranes, when you remove it, I stain it again. And in fact, in many cases where ERM is visible, I don't stain to start with, but I stain it after I remove the ERM. Otherwise, where I think that I would like to peel the ILM along with ERM, I stain it first, then lift the ILM away from the ERM and then remove it as a single complex if it is possible. But if I remove the ERM, I always stain and make sure whether the ILM is staining completely intact. Technically, if the ILM is totally intact, if you want to leave it alone, you can leave it alone. But very often you will find small patches missing. Then it's best to peel off the ILM also around the fovea. So you don't have to peel extensively the ILM like in a macular hole surgery, but for ERM, at least the perifoveal area should be clear.
Yeah, Girish, to add one more for that.
Yes, sir.
You have a sometimes just perifoveal attachment and firm attachment when you try to peel ERM alone, and you realize you are worried about if you try to peel that one, sometime you may deroof the fovea, cystic changes sometime. And in those cases, in fact, sometime if you leave that ERM like that and just start peeling, and then along with that take ILM, ERM complex together, somehow it comes off easily rather than just trying to forcefully pull the ERM.
Yes.
But it's very bad, very bad cystic macula where you're really worried about deroofing it. I would probably use a different technique of foveal sparing membrane peeling, where even the ERM also is not peeled across the fovea, but is peeled towards the fovea. In fact, as you're manipulating it, once it is freed all around, it just pops off, separates from the center without really deroofing it.
I think to add to that, the other situation is the myopic macular schisis detachments, where you would prefer not to peel around at the fovea, because our main goal is to reduce the retinal traction, and that's why the more you peel around the fovea, sparing the fovea is safer, because many of the studies have shown that if you try to peel the ILM at the fovea in a macular schisis detachment, in a myopia, you end up with a macular hole later on. So it's preferable that you just leave the fovea and do peel a wide peel around the fovea, and don't touch the fovea. That it helps. Of course, our primary goal is to release the tangential traction on the macula.
Thank you. So if I may ask Dr. Mahesh Shanmugam, is there any difference in the technique while planning for a surgery for an idiopathic macular hole versus a secondary ERM? Idiopathic ERM versus a secondary ERM.
I think he has a...
So Dr. Andrew Chang, if you're online, would you like to take that?
I think yes, could I have that question again, please?
Yeah, so is there a difference in the surgical technique while planning for an idiopathic ERM versus a secondary ERM?
That's right. Well, what I would do for a idiopathic ERM is assess visual function and structure, work out where the epicenter is and where to start. And in general, I peel the ERM, and then often the ILM will come with it. In a post-PVR membrane, the membranes are often thicker, and I find that it comes away much more cleanly than idiopathic membranes. And in PVR membranes, I don't go for the edge of the membrane. I go for where the fold is maximally, and I find it feels much better that way.
Okay. Dr. LG, would you like to add to that?
I think it's okay. It's all been well covered.
Okay.
Thank you.
Thank you. So one final question, maybe, what is the most effective postoperative strategy for preventing recurrence of ERMs? Is there anything that you do? Maybe give a steroid injection at the end of the surgery, or peel ILM in each and every case? Any thoughts on this? So, yeah.
Sorry, me. Well, to prevent ERM, I think traditionally we have peeled ILM. So we peel the ERM first, we stain with blue dye one more time. Often the ERM may have already peeled the ILM together, but if there's still some left behind, we open it. There is now increasing thought that we may be creating more trauma, more damage to the Muller cells by peeling the ILM. And at the recent Vail meeting, this was discussed. That would be, I think, the greatest tip. You mentioned giving a steroid injection, and I started doing this maybe 2 years ago. Dexamethasone into the vitreous cavity, 0.1 mil. And the eyes are much quieter in the first, day or two after surgery. And I'm not sure, because I haven't studied, in a randomized study, but my feeling was that there was less edema in the longer term. So I've started to do that.
Is there any specific group of patients where you would use it? Because you're talking about secondary membranes, not idiopathic.
Yeah, look, I pretty much use it in almost everybody, a 0.1 mil of dexamethasone, because that's usually what we give subconjunctivally. So I asked the nurse, give me 0.1 mil, and I give it. I give it almost in all cases, or even, in ERMs, maybe not in macular holes, but in ERMs. And the eyes are quieter. They really settle very quickly. So several of my colleagues in Sydney are doing this, and we've all found our eyes quieter post-operatively.
Does it help only to reduce surgery-induced trauma rather than epiretinal membrane? Because the half-life, when you look at it, dexamethasone, are hardly 30 or 40 minutes. I mean, that's I think I looked at it.
Correct. It would not reduce, recurrence of ERM, but it does reduce the inflammation in the first 2 or 3 days. I've noticed that. The eyes are very quiet the next morning.
I think I'd like to thank all the speakers and the panelists for the excellent discussion and for staying on with us for so long. And I hand it over to Rajiv to give the concluding remarks.
It was really a great session. We really enjoyed, and sorry for the initial technical glitches we had. It was great 3 days of learning on a topic which we thought may not be, it may not be a topic of a meeting itself, fibrosis. Thanks everybody. Thanks all the speakers. Thanks all the panelists and all the audience for being with us for these 3 days. I'd like to thank some of the people who made this meeting possible. It's a small video which I'll be sharing. Thank you very much. Good night.
Thanks, Rajiv. Good show. Good night.